Management of malaria is highly dependent on if it is complicated or uncomplicated. So there are standard guidelines globally that are documented everywhere and are readily available for you. But that, of course, is up to the healthcare worker to decide and determine what degree your malaria is. So for uncomplicated malaria, patients are able to swallow medicine. So the first line is the common coartem, or what they refer to as artemether with lumefantrine. It is a combination because it has shown in research to beat the resistant strain of malaria. Once this coartem or artemether lumefantrine is not working for the patient as first line, there is what they call a first line alternative. Now, this, of course, is particular for the healthcare worker who is giving it to you, but you'll hear somebody talking about artesunate with amodiaquine. And I know by now you're asking me, what about the children who are not able to swallow? The children have special formulation of what we call dispersible tablets. These dispersible tablets are just put in water and they dissolve, and some of them in the market are flavored. So the children will be taking it and it will be tasting like orange juice. So when you've given them first line and first line is not working, then you go to the second line. The second line is dihydroartemisinin piperaquine, but the common brands that people see are pialaxin, diocotexin, and so on and so forth. I'm not marketing any brands here, but just for easy consumption. That is usually a second line after the coartem has failed for uncomplicated malaria. When we move on to complicated malaria, it is standard practice or globally defined as malaria with the complications that have been listed. And this we manage with intravenous artesunate. Intravenous artesunate is given depending on the body weight of the patient and very particular. So they measure your weight and we titrate the dose or calculate the dose in accordance to your weight. So if you are 20 kilograms or above, we have a particular multiplication. And if you're below 20 kilograms, we also have a particular calculation. And we give this initial dose, in a 24-hour period. So we give one at the time that we have diagnosed you with a complication of malaria. We then give another one 12 hours after, and then 24 hours after. And depending on which particular complication, we may switch you to the oral medication when you're now able to swallow, or continue the intravenous treatment. It also goes to say that this management of malaria is not only for the distinct or specific malaria treatment to kill the parasite, but also the supportive management. This supportive management is to address the complications. For example, a patient comes in severely dehydrated. He has been throwing up everything he has been taking. He has been having a lot of loose motions or diarrhea. We have to give you back this water that you have lost in terms of intravenous fluids. We have to replenish you with, for example, ORS if it is a child. Then in case you're having severe anemia, we may need to transfuse you. In case it is renal failure, we may need kidney failure, kidney injury because of the severe form of malaria. We may need to give you treatment for the kidney injury. If it is respiratory and having difficulty in breathing, and your oxygen saturation is low, we may have to supplement you with oxygen as well through nasal prongs or masks. If you're low on sugar levels, we may have to also give you a bit of glucose as well, so that we replenish your sugar levels since you've not been eating for long periods of time. If the fever has also to be addressed, and that is why we will give you the fever medication. The commonly known one is Panadol, paracetamol, or diclofenac, or ibuprofen, or along that line there, I would say, so that the fever comes down. And we don't want to give these anti-fever medications for more than 3 days. Yes. So, of course, we urge people to come to hospital as soon as they feel these constitutional symptoms, because the longer you stay at home, the more probable it is for you to move from the uncomplicated state to the complicated state of malaria. And with this comes longer days in hospital. That means it affects you socioeconomically and also affects your family because they have to come and take care of you. But in the long run, these complications in some systems will leave you with permanent sequelae. Permanent disabilities. For example, untreated cerebral malaria will leave you with issues in the brain. You may have mental illnesses moving forward. We also have children who get convulsions because of malaria, because of high fevers, and because of high fever rather, and because they're not addressed in time, these children will then carry on to have convulsions or in their childhood and require long-term specialty care by specialists referred to as neurologists.